I appreciate the opportunity to speak at the QI Summit for the ACHQC, and I appreciate the invitation. Uh, this is a talk on insight from our members and really is about institutional and academic value. I'm William Hope. I'm a surgeon in Wilmington, North Carolina. So we're going to start by really kind of giving a brief overview of sort of what I think some of the values are of this platform, the QC. This really is about academic value, but I think that it goes well beyond that and really is about I think every surgeon can really take this, no matter what kind of practice you're in. So here's our outline. I'm going to spend a little bit of time on this because I think we're going to hit a lot of these sort of superficially, and hopefully you're aware of all these things that I'm going to be talking about. But there's a lot of great stuff that the QC is doing, and I want to hit the highlights. So obviously, the leadership of the QC wants to make sure there's value in the QC, and I think value may be a little bit different for every surgeon, again, based on sort of how they practice. But there's no doubt there's a lot of value out there depending on how you use this, but there's a lot of ways to do it. And I'm going to show you why I think data is important. I think we all probably feel that way. There's a lot of opportunity for quality improvement using the QC database, and I think a lot of those folks in our hospitals is really, I'm a residency program director, so quality improvement is something that the residents really need to be involved with, and I think hospitals are really engaged at this as well. You can use this for some hospital committees that you're on, obviously the quality committee, but one of the interesting things is maybe looking at this to use in a value added analysis committee about mesh, and I think we'll hit that as well. And I'm going to go over some examples of how the QC can change and support practices, both academic and institutional practices, as well as community practices. And then, of course, academic surgeons like to publish, so we'll go over a little bit about some of the publications. I think data is king. We've heard this for a long time as surgeons. I think we all are aware of this, that it's really important to know your data. And this is really, to me, the QC is one of the easiest and best ways to get a good, solid data for you, and it allows you to compare yourself to your peers. And sometimes that's not always fun, especially when you're not quite as good as your peers. And I'll show you some of my data related to that. But I think it's a way for us to get better. And this is, in most cases, a non-punitive thing, and it's just a way for us to learn from each other. One of the other great things about the QC is a lot of the hospitals that we work in, the data that they're using is really administrative data, which can be good in some ways and for some of the things they're doing. But for hernia, I think we always question, the accuracy of some of these big databases is really, whether they're good for us. And I think the QC metrics that we put in are really the ones that we want. And I think this is where you can get buy-in from your hospital, especially if you don't have a quality initiative around hernia, or if they're looking for something that, it's really great if you could get the QC to sort of be the quality outcome metric for your hospital, and then that'll allow other surgeons to get involved. This is an example of quality improvement from me. This was early on in the QC, and what I found was I was an outlier for 30-day readmission. And I think clearly the QC is great at looking at 30-day outcomes. Readmission, every hospital that I know of is really interested in readmissions. So that's partly how they get paid. So I was an outlier for 30-day readmissions, and after I kind of realized that that's probably true, and this was data I was putting in, so it is, and that other people were better at this than I was. Then I really kind of figured out that there were probably some readmissions that I was having that probably was low-hanging fruit that I can improve upon. And this is where Ben Palouse really helped at the beginning of this and did a great QI project, really looking at can we decrease 30 days readmissions, and in a fairly simple way. And this was a survey that you could have your nurse, and my nurse still does this. She likes doing this. Call our patients after surgery. We found that really, a lot of the readmissions were related to surgical site infections or bowel issues, and so there's some questions related to that. And if they answer yes to those, then what I used to do, or what my nurses used to do, was tell the patients just to go to the ER. And if I wasn't on call, the resident would see them and then just admit them, and I would see them the next day, and there was a readmission that we really didn't have to have. And so I think there's some ways to improve. Hospital loves this, even if you don't hit the target of something that you're trying to do. If you just show that you're working on some quality improvement initiatives using the QC, I think that's a major win. And like I said, residents and fellows need to do this. They need to learn how to do this. And so I think it's a great way to do it and an easy way to get some data. Hospital committees, besides the sort of quality committee, which we talked about earlier, I think one of the interesting things, we have not used this for this, but I think this is as I was putting this talk together, a potential great way to use this. As we all know, when we put in our mesh, what kind of mesh we use. And for the majority of this, I tend to use a lot of permanent synthetic, but I suspect if you looked at the surgeons in my hospital, you would probably get some very different graphs as they tend to use some different products and different types of meshes. And so if I was a hospital and interested in sort of decreasing our clinical variation, especially, if it was appropriate, then I think the QC could really be a good way to use this and look at our mesh use and make sure that we were doing all that appropriately, especially if we were bringing in new products. I think the QC has really gone a long way to change practice, and I think that's clearly one of the reasons this was started is to try to answer some of the burning questions that we have for hernia repair. That several of them still remain unanswered, but we've taken a good shot, and a lot of good investigators have really been thoughtful about looking at some of these things. But also supporting practice. And I can't go over all the different research projects, but of course you've seen some of these at the QI Summit, whether it be tap blocks or epidurals, or, do we need to put fixation in mesh, or, coated mesh, and all the different types of techniques. And I think they've done a great job at really answering some of these questions. And clearly, we've changed some practices because of that. But I also think the QC surgeons really support practice. And anytime I can put a picture of Mike in these silly hats, I try to. But this was interesting a few years ago, where there was a big stink about the AORN, guidelines about Buffon and surgical caps. And, the QC was very nimble and very quickly could get some data about surgical caps. And this was, again, a great way to use this. And we got some data, really one of the first papers out to sort of support the use of surgical caps, or really you could wear the cap that you wanted. And so very supportive to surgeons, whether you're in academic or community practice. The QC helped with that. Other things that the QC does, I don't know if everybody uses this, but it's a great tool, the brief op note. Most of us at the end of the case put in a lot of the stuff in the QC at the bedside computer. So this just decreases a step of doing your brief op note. Every hospital requires you to do a brief op note. It generates this for you, and you can just, copy and paste this into your electronic medical record. One of the great things about this is it allows for, it really gives you all the information that you would want in a brief op note, which we don't always put in if we're just typing this at the end of the case. And so if you were ever to look back at your electronic medical record, most of the good data would be in there. And then really another up and coming thing that hopefully everybody is familiar with or is starting to use is the Oracle. And I really think we've used this in a few different ways. Clearly the Oracle part, where you can sort of sit with a patient and go over some outcomes and risk factors and sort of give them an honest, based on the QC data, an honest interpretation of what their outcomes may be, I think is really important. And patients really do like that. But really where we've used this the most is really the prehab and rehab and sort of the exercises that patients can and can't do. And when I talk to my nurses, really the number one phone call we get amongst our practice about hernia patients is really what they can and can't do after surgery, despite us really talking to them before surgery and right after surgery of, giving them some clear guidelines. They still don't get it. And one of the nice things that our nurses do is they just refer them to the QC and the Oracle app. They pull it up, they see that some of the exercises they can do. I think they feel engaged with that. So we really enjoyed doing that. And I think our nurses really like that. So publications, obviously academic surgeons like to publish papers. They like to look at data. In some institutions, that's really important for advancement in careers. And so this is a great, easy way to submit a publication, submit a question to the QC. It does go through a process of where it make sure that it's a valid question and it's something that hasn't been done. But almost all of these get approved, and then you get to work with a statistician, a data person to give you some data. And you can see these aren't all the publications, but these are some from our group. that, whether it be a resident or a fellow that has done some of these, or a lot of these have been in collaboration with other surgeons. I think that's a great way, kind of get a group together and query the QC and get a publication out there. And clearly the number of publications and the impactful publications that come out of the QC is really great. But almost everybody can take part in this and really publish a paper, whether it be on your own data or using the entire QC. So in conclusion, of course, I think the QC is very important for academic surgeons and institutions, as well as community surgeons. And we see that from all angles, but even community surgeons can have some academic endeavors by using the QC. It clearly fulfills a lot of the goals of an academic surgeon of publishing, quality improvement. There's some grants that your residents or fellows can apply to. And while they're competitive grants, the number of grants that are submitted to this aren't as big as some of the other grants that you may be applying for. So there's a good chance that you could get this. Clearly, peer review publications is a great way to do that. It's a great way to get started with the QC and see how you can get some of these published. Of course, one of my favorite parts of the QC is really the collaboration that we have. And unfortunately, we can't all be together, because I think the Quality Summit has really been one of my favorite meetings over the past few years. And I think it's great to see like-minded folks and get together and meet a lot of people. So unfortunately, we don't have that this year, but hopefully next year. But one of the other great things that hopefully you're aware of, and if you haven't, I would really recommend it to you, is the QC Core Insights. They've had a few of these already. They've been spectacular. It allows for surgeons to talk about their research. It allows for some surgeons to be panelists on this and sort of, kind of debate some of this and really get to the bottom of some of these really complex and controversial questions. So the Core Insights is a great way to get young faculty members or people on, talk about these hernia situations and complex stuff. So I recommend all of these to you. I think, again, it's a great way for us to all, be a little academic and support our institutions through this process. So thank you very much.